These are some statistics from our registry population of patients pertaining to knee results. And it should be noted that the majority of these patients are knee replacement candidates, have been told by an orthopedist, maybe multiple orthopedists, that they need a knee replacement. There's different ways to cut and slice the statistics. What we see in the upper graph is the percentage of patients that report greater than 50% improvement. That's one way of looking at it. So when you look at 1, 2, 3 years, we've got almost 70% of the patients reporting greater than 50% improvement in their pain and their function. Another way of looking at it is the mean improvement of all patients. So we know that about 90 to 95% of patients do report improvement when we check on them at a year and beyond. And when you average out all that all those patients, some with mild improvement, some with complete improvement, on average we'll see about 55–60% improvement in pain and function in these very advanced conditions. We're happy with these results. Very consistent. It doesn't seem to matter if you have very severe arthritis, you're still likely to get this degree of improvement. Age does not seem to matter in the statistics, although I can tell you from my experience that once patients get into their late 70s, mid-80s, for example, there's a lot less stem cells, a lot less volume of stem cells. But this can vary from person to person, and especially depending on their vitality and their general health. So more specifically in the knee, we have the ability to treat some ACL tears. This is a side view of the knee. You can see that ACL runs from the back to the front like that and provides stability so that the lower bone, the tibia, can't move forward too much as compared to the top. So it's a very important stabilizing ligament in the middle of the knee. It's commonly torn in certain activities. We see it in soccer and football, for example. Different types of blows to the knee can create tears. We can see degenerative tears. The ligament just can weaken over time, or it can be traumatic. And you can have a complete non-retracted tear. That is, that the ligament is no longer intact. However, it remains in close proximity to each end, remains in close proximity to each other. So if we can get stem cells in there, which we can do with very precise, somewhat difficult injections to do using X-ray and ultrasound, you can get partial tears to fill in on MRI. You can get complete tears that are still close together to fill in an MRI. But however, if you have a stump here and a stump here and this wide distance in between, and really at that point your only choice is surgery. But we're very excited about being able to offer this procedure to a lot of people who have these kind of injuries. And this is just an example of a ACL ligament, which is a strong ligament in the middle of the knee that provides important stability. When treated with precise injection of stem cells, we get a healthy looking ligament at follow-up MRI. Meniscus tears that are symptomatic, and not all are symptomatic, often improve quite significantly with these procedures. Shoulder statistics. Here's some national registry data pertaining to shoulder pain. Perhaps from shoulder arthritis is included in this data, anywhere from mild to very severe arthritis. Rotator cuff tears, which are very commonly seen and very well treated with these procedures. There's also a type of tissue within the shoulder. It's called the labrum tissue, which can be torn sometimes in people who do overhead types of activities repeatedly. In general, the results in the shoulders are quite good. What we see is good mean improvement from the patients. We typically tell people is about 70% of the patients have more than 70% improvement in pain and function when we check with them at a year and a half. That doesn't mean that the other 30% get no improvement, but they may get a little bit less than 70% improvement. Okay, let's talk a little bit about Regenexx procedures. There are different kinds of back-related pain. It could be pain related to ligaments in the back, to joints in the back, to the discs in the back. The nerves can get pressed on and people can feel pain down the legs, sciatica or pinched nerve type sensation. This particular chart here is referring to pinched nerves or sciatica type symptoms. What's commonly done is what's called steroid epidurals. Epidural is a space that surrounds the back of the disc and also around the nerve that leaves the spinal cord that goes down the legs, and people feel pain in distribution of that nerve when it's getting pinched or irritated or inflamed. They have these type of sciatica symptoms. So the concept for many, many years has been using steroid epidurals, put it into this space, try and decrease the inflammation. But we have been using for quite some time now Regenexx platelet lysate. So just the growth factor from the platelets, instead of putting steroids into this epidural space, we put the platelet lysate growth factors into this space. And so when you look at these patients who have these symptoms in this particular study, we've seen that the people who had the steroid epidural, this is a functional pain scale, have very little improvement, whereas those who've had the Regenexx platelet lysate, we call it a PL disc procedure, have quite a significant amount of functional pain improvement at 3 months. You can see they're following a different trajectory. The steroid epidurals at 6 months have even less improvement, whereas the platelet lysate continues to have a fairly good amount of improvement at 6 months. And we have more data that's getting ready to be published, and it seems to be in line with this here. Now, also people can get, especially as you get older, 50s, 60s, and 70s and beyond, the disc can degenerate significantly. The ligaments in the back can degenerate and get weaker. The joints in the back can get arthritic. And you can even get some slippage of the vertebra on the other vertebra as the ligaments in the back get weak. So for people who have degenerative disc disease and arthritis in the back, we want to try to strengthen the tissue by injecting the different ligamentous structures and the joints in the back. We know that when surgery is done for back pain of this kind, the two segments are either fused together or some metal hardware is placed to try and stabilize. But the body has natural stabilizers that we want to try and encourage to get stronger, and those are the ligaments that are seen here in the red. And we can inject that with prolotherapy solution, platelets, or even bathe those areas with stem cells. What's very exciting is that in younger people, before the discs have completely degenerated, people who still have some disc height left, they can get these tears in the back of the disc. And these tears can be severe causes of pain. So about 40% of back pain is because of these disc tears. And they can persist, and they don't have to be very large. So some of the material from inside the disc, you can see that here in this image, leaks out of this tear and can get onto the nerve, and that can cause inflammation of the nerve, cause pain down the leg, or it can be actually just back pain. People who have a tough time sitting for any period of time or lifting anything, coughing, sneezing can cause pain. So this can be a very effective strategy for the right patient. It's a little bit higher risk because you're going deeper into a disc. It's probably not the first thing we're going to do if you have back pain. We probably want to do the epidurals, do the ligaments in the back, and see if that helps get things better. There's been one well-done study that showed that there was a lot of improvement with the use of PRP in the discs. We're using platelets, we use stem cells, and we can use the culture expanded stem cells down in the Cayman Island. So there's more research to come, but this is a very, very promising field, and we are doing this frequently within the network. Okay, let's start talking about Regenexx Statistics for the hip region. procedures, there are multiple different areas that seem to come up frequently. One of them is, and the labrum is a rim that sits at the edge of the cup of the ball and socket joint. It's softer than the bone. It's similar to a meniscus tissue in the knee. There's also a labrum in the shoulder. These can be effectively treated with stem cell procedures. Femoral acetabular impingement is a condition in where, if you picture the ball inside of a cup, the ball can get a lump on it, or the cup can have a growth of bone coming off of it, so that when the ball tries to move within the cup, the labrum can get pinched, and this can lead to labral tears. And although the bone growths won't go away, the condition can still be effectively treated from a symptom perspective with the stem cell procedures, and it can strengthen the tissue that's getting pinched so that it no longer feels irritated and painful. Many different tendon issues come up regularly in the hip. We have something called the abductor cuff, which is similar to a rotator cuff. There's the hip flexors called the rectus femoris and psoas tendons, as well as toward the back, the hamstring, piriformis, and other tendons. These are generally quite effectively treated with platelet procedures, although when there are larger tears, we can go ahead and treat that with stem cells effectively. And then hip arthritis is probably the most common thing we see. It'd be nice to see them when they were early, but generally speaking, people come in and it's already moderate, severe, or even more than severe, called end stage, in which the ball and the socket are virtually one unit, almost no spaces left, and people have severe range of motion problems, and lots of lumps and bumps develop all over the bone. This can be treated, and I'll talk about that here in a moment a little bit more. And then there's avascular necrosis, known as AVN. AVN is a condition in which the blood supply to the bone has been lost for some reason, and then the bone itself stops receiving nutrition, and therefore the bone starts to die. We call that necrosis, and avascular means no blood supply. So the outside edge of the bone, or the ball, can actually collapse inward, and you can lose the actual shape of the bone, and it can just kind of become quite deformed and abnormal. This can occur from two directions. It either can start as a loss of the bone, and therefore they get the avascular necrosis, and that's the common way we think of it, and usually in younger people. But it can also occur where someone develops very severe arthritis and then develops a little bit of avascular necrosis in response to the area, to the arthritis, because of the pressures on the overlying bone. Either way, the avascular necrosis can be treated effectively. Well, I shouldn't say either way. The avascular necrosis can be treated if it's in its early stages. In the later stages, we've been able to see this halt for a period of time, but it's likely that it would need to be treated again sometime down the line. So when we're looking at our statistics for these conditions, it should be noted that if people have severe or end-stage hip arthritis, I'm really going to be encouraging as your best non-surgical and non-drug related treatment to do a Regenexx procedure in the Cayman Islands, so that you can get the culture expanded stem cells. In this case, we can get much larger quantities of stem cells, and we seem to have more consistent good results with the Regenexx culture expanded procedure for these advanced severe and end-stage hip arthritis. There are times that we treat it here in the U.S., and I think these statistics here are generally for the majority of the numbers calculated in here are for severe arthritis. And so we do see some benefit, but we can see cases in which there is no benefit. But on average, we are seeing 40, 45, 50%, and at 1 year here, we're even over 50% improvement in pain and function. That seems to be where it plateaus and then starts to drop off. At that point in time, I would recommend every 6 months adding a platelet procedure. This is again for the more severe arthritis. And then if there's going to be a repeat stem cell procedure, which may be indicated in some instances, the best window of opportunity seems to be between the 6 and 12 month point, Although it can be done at any point later on, doesn't mean it won't be additionally effective. It just seems to be that's the best window. So other commonly treated areas include thumb arthritis. You can see that up in here. Various conditions in the feet. There are tendons along the sides that can become problematic. Arthritis in the ankle, arthritis in the toes. Elbows are another common area. The outside elbow, where people call tennis elbow. The inside, called golfer's elbow. And various other conditions of the elbow. So, just a little bit about some evidence regarding these platelet injections and tendons in particular. This one study was looking at platelets for the use of for treatment of these chronic tendon problems. We call them tendinopathies. Not tendonitis, but it's a degeneration and a weakening of the tendon. So we looked at it for tennis elbow, golfer's elbow. This particular study looked at all these different types of tendons in the knee, the Achilles, the bottom of the feet, plantar fascia. On the side of the hip is a problem, off rotator cuff and hamstrings, biceps, triceps, etc. Most of these patients had tried the standard treatments and were not getting success. So with these platelet injections, in these patients who were not getting success with these other treatments, 82% of them were able to obtain moderate to complete resolution of their symptoms. About 60% of them we were able to get there with one injection. Another 30% needed 2, and another 10% needed 3 or more platelet injections. This is what I commonly quote people. I can't tell you if you're going to be needing 1, 2, or 3 or more injections to get to resolution of your problem, but I can tell you that if we continue to do it, 85% of the patients will get to a place where they're satisfied, even though they've had this condition for on average 1.5 years or more, some of them 5 years or more, and tried everything else. This procedure can be helpful. Of course, any new type of procedure, we need to verify that it is safe. And no one has done more work on this type of research than Regenexx. Regenexx has published the largest safety paper in the world, with more than 3,000 cases published in this report, with some of them going up to 9 years of follow-up. And what we know is that it is safe. It is as safe as any other injection procedure, perhaps safer. And there really were no serious side effects, as you can see with surgery. So people like to compare these procedures to surgery. But really it's night and day when we're talking about the safety profile. These are safer procedures. There's a lot less to lose here as opposed to a surgical procedure. It makes sense to try these prior to going to a more major surgery.